Mr. Chief Clerk.
Mr. Speaker, engrossed House Bill 1362, introduced by Representative Carlson and other House sponsors. Engrossed House Bill 1362 is a bill for an act to create and enact a new section to Chapter 50-24.1 of the North Dakota Century Code relating to Medicaid expansion, to provide for an appropriation to the Department of Human Services for the expansion of Medicaid assistance program, to provide for a legislative management study, to provide an effective date, and to provide an expiration date. Mr. Speaker, your Human Services Committee recommends amendments as follows, and when so amended, recommends do pass by a vote of 13 yeas, 0 nays, 0 absent, and 0 not voting. Mr. Speaker.
Representative Becker.
Thank you, Mr. Speaker. I'd like to request division of this bill into two parts.
In accordance with House Rule 319, any member may have the question divided. Each division of divided question requires the same vote for adoption that the division would require if it stood alone. After voting, all the divisions approved compromise the question before the House. Representative Becker's question or request is granted. House has before it division.
Mr. Speaker, Division A would include sections 1, 2, 4, and 5. Part B would include section 3.
Representative Becker, Division A was 1,
2, 4, and 5.
Okay, thank you. And Division B was just 3.
That is correct.
Thank you, Representative Becker. You may continue. On, let's see, the House has before Division A, Representative Becker.
Thank you, Mr. Chairman. Members of the Assembly. This bill is quite important. Expansion of Medicaid is something that we have to look at very, very seriously. And I believe over the course of the discussion we'll have on the floor here, there will be some compelling arguments for expanding it. And I'd like to touch on those very briefly before I try and give you my compelling argument why we should not expand it. Number one is that with the ACA or Obamacare, we have had numerous taxes placed on us, quite a plethora. They're all over the place and they're unavoidable. What I would suggest to you, though, is in microeconomics there is a term called sunk cost. These are costs that we've had, they're incurred, we don't have a choice, it's done. Any decision we make from this point forward doesn't affect that. So we have to look at the pros and cons, the cost effectiveness or lack thereof based on everything going forward from this point. Because we haven't paid for it, quote unquote. What we have to do is determine what are our costs in the future, because the costs in the future are what are paying for it. The second thing that we might look at is a Medicare reduction. In the ACA, there is a reduction in Medicare reimbursement for facilities of about 2%. It does definitely make it more difficult for providers. Now, some of this is mitigated. This downside is mitigated by what is called woodwork effect and crowd-out effect, and I'll address those in just a minute or two here. But I want to acknowledge also that the possible 2% cut in Medicare pales in comparison with a possible 25% cut to providers if federal government doesn't keep reenacting the SGR formula. So although a 2% cut, and again it's mitigated, it won't be a flat across the board because of other effects, completely pales in comparison to some other sort of falling off the cliff type of scenarios that we have coming before us. The other aspect that I would touch on with that particular concern is that what we're looking at is in our healthcare exchange will further mitigate the downside to losing some of the Medicare funding because more people are going to be in. If you take into consideration that it's a give and take, all of the costs are a give and take. The federal government took by reducing Medicare. We want to be able to see that our hospitals and clinics are reimbursed fairly. Some of that, what was taken, will be given back in the sense that more people who are not currently on an insurance plan will be under the healthcare exchange. Medicaid expansion would further that, but again, we'll address that in a second. The last thing I would say that would perhaps be compelling to me would be that the committee had a 13-0 vote, and I think that should be taken with a grain of salt. Sometimes amendments are confusing and they're quick, and this is a very complex topic, and I suspect that there may be not an entirely unanimous feeling about that. If you would, anyone interested, be so kind as to look at this colorful graph I gave you, I'd like to talk about some numbers, because we have to look at how many need coverage versus how many are going to get coverage. Now, back in 2010, I was witness to a report from an interim committee that discussed that North Dakota had 2.3% of its population that did not have insurance coverage because it couldn't, because it either couldn't afford it or it had pre-existing exclusions, things like that. Now, that's 15,000 people. ACA will reduce those 15,000 people in several ways. One, we're now dependents up until age 26, so some of the people that were in their early 20s didn't have coverage can be covered. It eliminates pre-existing exclusions, so that will drop that 15,000 down further. It will now provide coverage at 100% of the federal poverty level with its health care exchange. That drops the 15,000 further. And what we're looking at, and what the committee looked at, was an estimate by a Kaiser study that we would be looking at 22,500 people. Now, in my opinion, from the reading I've been doing, that minimized somewhat the woodwork effect, and it didn't take into account the crowd out effect at all. Now, the woodwork effect is there are a number of people who could be covered but didn't fill out the paperwork, weren't aware of it, or just didn't care enough. And in fact, in that interim study I was talking about in 2010, that was an additional 15,000 people. The crowd out effect is, as ACA is implemented, it's going to be harder and harder for employers to give their employees insurance. When they see that there is an alternate route for patients or for people that are lower income, they're going to push them off, and those people will now have to go on the Medicaid rolls. The other possibility is that they may be paying for their insurance premium or part of it, and may find that it's cheaper and will jump off voluntarily from their employers to the Medicaid rolls. So if we look at the graph on the top, currently the situation is this: Medicaid covers up to 83% of federal poverty level. I threw in the different colors there because there are exceptions to what's covered and what's not. But if you notice, above 83%, it's white. Those are the people that are not covered. Now, if you go to the middle section, that is a scenario where we do not expand Medicaid, and the federal government still implements its health care exchange. So the health care exchange is in blue. That covers everyone from 100% of poverty level to 400% of poverty level. Our Medicaid still would stand at 83%. Now, there is that narrow window in between that's referred to as the donut hole. Now, it's important to keep in mind, we're not taking insurance away from anybody. Nobody that has insurance will now be without insurance. These are people that didn't have it. Unfortunately, if we don't expand Medicaid or do something, they still won't have it. But that's what we're looking at, this narrow window. The third and bottom diagram indicates if we do Medicaid expansion. And you notice there that there's a lot more red. That's, I'm sorry, did I say Medicare? I meant Medicaid. Medicaid expansion. So that's the red. It's vastly expanded. It goes from 0 to 138%. So there's overlap from 100% of poverty level to 138% of poverty level. So that's more than triple the size of the donut hole. Not only that, but it doesn't take into effect the crowd out. We're going to have a whole bunch more people that are going to come off of their employers' policies and jump on board. Now, the CBO, Congressional Budget Office, estimates that 30% of new Medicaid enrollees will be found from that crowd out effect. So that's really significant. The last thing about the numbers that I'd like to talk about is that when we look at all these effects, these CBO estimates, et cetera, it might be more reasonable that we would have in excess of 32,000 new enrollees versus the 22,500. Now, in 2020, when we have 10%, when the federal government sees it fit that we only have to pay 10%, that brings us up to $17 million a year. That's our cost. Now, if FMAP, the federal medical assistance percentage, drops down to 70%, that would put us at $37 million a year. If it drops to 50%, that's $57 million a year. Now, I hope that we can have enough foresight to see that this is very, very possible and very likely. Right now, North Dakota has an FMAP of 52%. It ranges from 50 to 70 some. There are 20 states that have an FMAP of greater than 62%. There are 7 states that have an FMAP of greater than 70%. Now, as we go forward and the federal government continues to spend money it doesn't have, and it looks to states that have a surplus, I can personally guarantee you, I believe, that we are going to be one of the first where the FMAP drops, and drops precipitously. So the idea that there's this free money, we got to take it, we have to look very carefully at the pros and cons, what the possible cost outlays are going to be. I believe that with some study, some insight and creativity, like Missouri, the state of Missouri has been trying to do some creative things. We could cut costs by injecting competition, requiring some out-of-pocket expenses for participants. They need a little skin in the game. And judicious selection of who could enroll. We could cover our uninsured for significantly less than the cost of the proposed expansion under the federal guidelines. By dividing the bill, we have the opportunity to say, let's take a serious look at how we can fill that small donut hole. Let's do the study, which will be voted on in Part B. And if it is determined by the study that, in fact, expanding Medicaid is a great idea, we can do that. We can jump on board in 2 years. If it's determined that we need to find Plan C, we can do that. There's no need to rush here because of the federal timeline. I think we can be wise in our decisions, be very thoughtful, and not feel compelled to rush forward into something that will last for many, many years. You'll also hear, as amended, that this is not an entitlement. And I will tell you that if I give someone a very pretty red flower and the stem has thorns on it, and I tell her it's not a rose, she's going to walk away and say, Representative Becker just gave me a rose. It's an entitlement. If it smells like a rose, it is. There is no taking it back once you give it. Once you give it, it's done. I think we all know that. Thank you, Mr. Speaker.
Representative Weiss.
Thank you, Mr. Chairman, or Mr. Speaker, members of the Assembly. I'm not sure where to begin here. I guess first I need to correct some of the inaccuracies having to do with Medicaid and what's covered and what isn't. First of all, the expansion is covering a group that currently isn't covered at all. There's no 83% or anything like that. They're not covered. We have to be clear on that. This is an expansion. It has nothing to do with previously eligible. They are currently eligible to be covered now under ACA. They will be brought in between the exchange, between the advertising, you might say, and the push by the feds, because under ACA, everyone needs to be covered. There's an individual mandate in place. It's not my idea, it's the federal law that's upheld. So those that currently qualify for Medicaid, they will be added to the rolls. Whether we do this expansion or not, they're going to be added to the rolls. Our current Medicaid program, and I'm not sure where the 83% comes from, because if our current pays 100% net of poverty is covered for children ages 6 to 19, and that's net income, not gross. It will be changed to gross, but it's net. The expansion is based on gross income. Pregnant women and children up to age 6 is 133% of poverty. Transitional Medicaid is 185. Workers with disabilities, 125% of where the 83% comes into play and that's what's called the medically needy. The option of someone who does not qualify under these levels, they can buy down basically their insurance. If they can buy it down to that 83%, then they can qualify. So one, we need to clarify, there's no 83% of Medicaid coverage anywhere. And again, this expansion starts at 0. There are not currently any coverage for this group. This group is age 19 to 65, childless adults. This is what the expansion involves. Currently, we have never covered that group, and that is correct. But because of ACA, whether I agree with it or not, it's the law. Supreme Court has upheld it. I don't like it. But I don't have that decision. Nobody asked me to come to Washington and tell them what to do with it. So we're stuck with it. But the point is, there is at least 18 new taxes that go into effect to pay for the Medicaid expansion. Whether we go forward or not, the state citizens will end up paying those taxes. That's a given. As Representative Becker pointed out, there will be a Medicare reimbursement decrease. That happens regardless. It was put into place to help pay for the expansion. Whether we do the expansion or not, it goes into a place. It will cost the state citizens because in the end, we all pay for it. If the provider takes the hit, eventually it's going to be higher costs on the other end and increased premiums. The next point is the exchange. Currently, there is what I call a donut hole. This new group that qualifies for the expansion, if they have less than 100% of poverty, and for example, for a single individual, that's $15,400. If it is a couple, it's $22,000. Or excuse me, that's at 138%. At 100%, they'll be making approximately $12,000. Now that group, if we don't do the expansion, qualifies for nothing. There's no subsidy. They can't go on the exchange. That is the law. The group at 101% to 138% does qualify for the federal exchange. Currently, the estimate by the Department of Human Services, the best we've got, because we have no hard numbers, they're anticipating a total of 20,500 individuals are within 0 and 138%. Of those, 7,000 are between 100 and 138%. Those 7,000 individuals qualify for the federal exchange. Now, so we're clear, that doesn't give us out of the picture. The maximum that those individuals will pay for a premium is 2% of their gross income. So do the math. If you're making 15 grand, that's $300. The average premium is for a bronze plan is probably going to be somewhere of $4,000 a year. Someone's making up that difference, and you know who it is. It's the policyholders in North Dakota. The estimate I received is that it'll cost North Dakota policyholders between $22 and $27 million a year to move those into the federal exchange. So let's be clear. One, we're going to pay the tax, and I agree the government's broke, $16 trillion in debt. Can't argue that. But they are taxing us to pay for the expansion, and we're paying it. So we're paying that tax. Our providers are accepting a lower reimbursement to pay for the expansion. If we don't do the expansion, not only are we paying all those, we are transferring them, shifting them to the policyholders of the state of North Dakota to pay the subsidy. So we're giving at least a triple whammy to the citizens of the state of North Dakota, plus for 13,000 individuals, they're still without any coverage, which means the charity care and the bad debt for our providers is still going to be there. We got an estimate from just one hospital here and I won't mention it, one of the major ones, estimated that Medicaid expansion would probably save them $2 to $3 million a year in bad debt and charity care costs. Now, the fiscal note that was given us shows it'll be approximately $103 million of federal dollars and about $173,000 for state contribution for administration. Now, stop and think, people. If it's going to cost $103 million, somebody's paying that cost today, currently in the state of North Dakota. Either that individual who may be paying some of that, but you have to realize at $15,000, I doubt he's paying a whole lot, or is able to. Who's paying the balance? Our medical providers in the state of North Dakota. I mean, that's just the way it is. You can't, the numbers add up. Now, do I like the fact that we got boxed into here? No. I can find a lot that I don't like about the ACA Act. I could talk for an hour about all the different provisions and the things, and I firmly believe it'll increase our costs of health care in the nation. But that's not what we're debating here on the floor today. The decision we need to make is we have a national policy, it's been upheld. What are best for the state's interest and the interests of the citizens of North Dakota? Whether I like this or not, to me, is not relevant. What's relevant is I have to be able to go home and say, I did what's the best advantage for North Dakota and for its citizens. And I'm not sure how I go home and explain to someone that if you make $16,000 a year, you can probably buy insurance for $300 a year, and if you make $10,000 a year, if you do want to be insured, you're going to pay $4,000 a year. How do we go home and explain that to that core constituency? Now, did we ask for that box to happen? No. I think it was not thinking when they did that in the ACA Act, but it is the law. We have to address that. So while I intended to have the whole thing on the bill, I realize we're dividing the amendments, but basically what we're dividing in this bill is whether we should do the expansion or not. We put a study in place, not because the study could stand on its own, because I don't think it can. If we just do a study, what are we going to study? We won't have the data that's necessary. We won't really know how many people are going to come on the system and how much it'll cost. We'll have no idea because, frankly, we don't know what that age group will have for costs in medical. I mean, we know on our current medical eligible, we don't know in that group. So the point of the study was, we'll come back. It has a sunset clause. I think everybody can see it and is aware of it. We'll come back. We can evaluate. We'll know how many people got on the expansion. We'll understand where the feds are at that point. Maybe they are pulling out. Now, is it easy to make a decision to back out of a program once you started? Absolutely not. I've been here a long time. I realize how that works. But again, we're entrusted to make the tough decisions. So to just assume that we don't have what it takes down the road to make a tough decision, I think is selling the legislature short. But we have to look at the decision today. It is 100% federally funded because we're paying a tax to do that. And should we take advantage? And if we don't, we will increase the cost to our businesses that have to insure their employers because they're all going to pay that tax. We're increasing the cost to our medical providers because not only are some of their costs increasing, we're reducing their reimbursement rates, and we're doing nothing to help the bad debt or charity care. And as we know, there's a bill in the legislature this session, bad debt and charity care are a real issue for our hospitals, particularly our rural hospitals. So I would hope we would resist this division. We would look at the bill as a whole. I think we took and made steps necessary to limit it, to take a look at it, make sure we're doing the proper thing. If we come back in 4 years and we decide there's better alternatives, if the federal has changed the rules, which they can, and I realize that, That 100% may change. The 90-10 may change. I can't guarantee that. Our current FMAP can change, and it has. When I got here, it was 72%. And we've had to pony up. That's the way it is. But at the same time, I don't see anybody here suggesting we turn back that federal funding that we're currently doing for Medicaid. If we're so concerned that we can't afford it, then let's send it back and fund it at 100% state. This is a program that I think is best for the citizens of the state. I may not like the direction that ACA is taking us, but we have to look from a state's perspective. And I don't think it's fair for me to ask the businesses and the individuals in my district or any other district to pay for all this and not get a single benefit out of it. So with that, Mr. Speaker, I would hope we would resist the division and then go on and pass 1362.
Is there further discussion? Representative Lauser.
Thank you, Mr. Speaker. Members of the Assembly, I'd like to read excerpts from a speech, joint session of Congress regarding health care, September 2009, and I'll skip the moments of applause. This is from President Obama. Finally, let me discuss an issue that is of great concern to me, to members of this chamber, and to the public, and that's how we pay for this plan. And here's what you need to know. First, I will not sign a plan that adds one dime to our deficits, either now or in the future. I will not sign it if it adds one dime to the deficit now or in the future, period. And to prove that I'm serious, there will be a provision in this plan that requires us to come forward with more spending cuts if the savings we promised don't materialize. Now, part of the reason I faced $1 trillion deficit when I walked in the door of the White House is because too many initiatives over the last decade were not paid for, from the Iraq War to tax breaks for the wealthy. I will not make the same mistake with health care. Reducing the waste and inefficiency in Medicare and Medicaid will pay for most of this plan. Now, much of the rest will be paid with revenues from the very same drug and insurance companies that stand to benefit from tens of millions of new customers. Now, add it all up. The plan I'm proposing will cost around $900 billion over 10 years, less than we've spent in the Iraq and Afghanistan wars, and less than tax cuts for the wealthiest few Americans that Congress passed at the beginning of the previous administration. Most of these costs will be paid for with the money already being spent, but spent badly, in the existing healthcare system. The plan will not add to our deficit, end quote. February 26, 2013, just yesterday, the Government Accounting Office reported the Obamacare will increase long-term deficits $6.2 trillion. I've heard similar promises before, live and in person. I was a guest of a member of Congress of North Dakota at a joint session of Congress at the Capitol in September of 2011. If I understand this correctly, the federal government will cover 100% of the costs if we enroll now, and in the future, that amount will be reduced to 90%. Is it possible that there will not be enough money to cover the federal government share and the inflated costs might get shifted to the state? Would a good indication that the federal government might not have enough money be the expanding federal debt and deficit? At what point does a red flag indicate a problem? $16.6 trillion and counting. For those of you that have a calculator that doesn't go that high, that's 16.6 thousand billion dollars. The speech I quoted was from 3.5 years ago, and look where we find ourselves today. Do we expect to find ourselves in a better situation in 3.5 years? History is a not-so-funny way of repeating itself. Ladies and gentlemen of the Assembly, I just can't help but feel like we're being forced to play the role of Charlie Brown and Lucy's holding the football. I'd encourage a red vote.
Is there further discussion? Representative Kaiser.
Mr. Speaker, I rise just to make a couple of what I think are corrections in statements that were made. It was stated that citizens in North Dakota may not qualify for the exchange. That's not true. Every citizen, whether it's a state-based or federal exchange, qualifies for the exchange. They may not qualify for the subsidy available in the exchange. That's a very different situation. So that's the first misstatement. The second thing I want to mention, you did hear about the impact on the healthcare facilities in the state. A study done in 2010 estimates that in the average American healthcare family plan, that approximately $1,006 is attributable to uncollectible accounts receivable at healthcare providers and facilities. So whether or not you vote for this coverage or not, given that we have another federal law called EMTALA, which requires every hospital facility that takes Medicare or Medicaid reimbursement to accept and fully treat anyone that presents themselves at an emergency room, regardless of ability to pay, must be treated. And so if we don't, as a state, find a solution, whether it's this one or one designed by the state of North Dakota for our citizens, we will continue to assess every family plan in the state over $1,000 annually. We will continue to have all of those uncollectible receivables at our healthcare facilities, and those are problems that have to be resolved with some kind of solution.
Is there further discussion? Representative Casper.
Thank you, Mr. Speaker, members of the Assembly. I have in my hand an article from the New York Times dated February 25th, 2013. The headline, "States Can Cut Back on Medicaid Payments, Administration Says," by Robert Peer. I'll read some of his points. The Obama administration said Monday that states could cut Medicaid payments to many doctors and other health care providers to hold down costs in the program, which insures 60 million low-income people and will soon cover many more under the new health care law. The administration's position, set forth in a federal appeals court in California, has broad national implications as it comes as the White House is trying to persuade states to expand Medicaid as part of the new law. I repeat that, as it comes as the White House is trying to persuade states to expand Medicaid as part of the new law. Going down a couple paragraphs. In a brief filed with the United States Court of Appeals for the Ninth Circuit in San Francisco, federal officials defended a decision by California to cut Medicaid payments to many providers by 10%. Kathleen Sebelius, Secretary of Health and Human Services, approved the cuts in October 2011 after finding that beneficiaries would still have adequate access to the wide range of services covered by Medicaid. The Obama administration urged judges to uphold these cuts, which are being challenged by patients, doctors, dentists, hospitals, pharmacists, and other healthcare providers in California. It goes on further down. Medicaid is one of the fastest growing items in state budgets. Cutting payment rates saves money for states and for the federal government, which will pay most of the cost for people who become eligible for Medicaid under the new law. In an interview, Dr. Paul Finney, president of the California Medical Association, a plaintiff in one of the court cases, said, "Two-thirds of doctors in California cannot afford to participate in Medicaid because the rates are so low. The problem will only get worse if rates are cut as we move more and more people into Medicaid." In court papers, the Obama administration said, and I quote, "It is entirely appropriate for a state to review its Medicaid plan to determine whether it can continue to satisfy its statutory obligations at lower payment rates," unquote. Indeed, the administration said states should conduct such reviews to avoid the perpetuation of payment rates that are unnecessarily high. Federal law says Medicaid rates must be sufficient to enlist enough providers so that Medicaid beneficiaries have access to care at least to the same extent as the general population in the same geographic area. And it concludes by stating, the Obama administration said California officials had agreed to monitor beneficiaries' access to care and to take prompt action if any problems are indicated. The administration said there is no general mandate under Medicaid to reimburse providers for all or substantially all of their costs. Administration statement. Mr. Speaker, members of the Assembly, the way I see the Affordable Care Act, Obamacare as it's called in the article, is a method to transfer the cost to the states, plain and simple. Reduce Medicaid payments, we're caught on the hook with more and more of the costs. I don't know if we should be expanding Medicaid at this time. I think the better approach is to do the study and wait and see. Thank you, Mr. Speaker.
Is there further discussion? Representative Jay Nelson.
Mr. Chairman, or Mr. Speaker, and members of the Assembly, to Representative Casper's point, I think that's addressed in the bill on page 1, on, beginning on subsection 2 in line 15. The Department of Human Services shall inform new enrollees in the Medicaid medical assistance program that benefits may be reduced or eliminated if federal participation decreases or is eliminated. Then it goes on to say the department shall implement the expansion by bidding through private carriers or utilizing the health insurance exchange. So this is not utilizing the Medicaid program in the state of North Dakota. This would be bid out to private carriers or they'd go on the exchange. So that is, I just wanted to clear that point.
Representative Porter.
Thank you, Mr. Speaker, members of the Assembly. When we had this hearing scheduled down in the Brynhild Haugland room, I was the last person that ever thought that they would be standing here telling you to vote for Division A. I went into that hearing thinking there is no way that I'm going to support anything to do with the Affordable Care Act. And keep in mind what the Supreme Court of the United States said, that this is not an insurance bill. It's not an insurance program. It's not even a health care program. It's a tax bill. That's why it passed the muster. So as we're talking about this, just keep those things in mind. But, you know, I did go in there with an open mind to listen to what the experts had to say. And they said a lot. They told us that the component of the Medicare reduction, that $700 and some million that comes off automatically from the providers, goes back to Washington. You don't have to get it back as a state. Your providers don't have a way to get that money back. It's gone. Wave goodbye. If you don't do something on the other end. So this program's paid for with one of the 14 taxes inside of the ACA and the Medicare reduction. This is paid for. So you take the largest payer mix that any health care provider in the state of North Dakota has, their Medicare population, and you take that revenue away from them. There's no way to recoup that. The charity care is still there. The uncollectible debt is still there. The population that this bill is attempting to help are the most vulnerable citizens in the state of North Dakota. And there's one thing that I have always said I would do, is to stand up for the most vulnerable citizens in this state. That we are the safety net before they hit bottom. And this is part of that safety net. So as we look at this safety net and we think about what we're doing here today, our providers who are already faced with unbelievable amounts of uncollected debt. Last year, it was $225 million in North Dakota of charity care and uncollectible bad debt. Now, that may not sound like much to a place like this where we talk in billions of dollars every day, but the one thing that this division will do, if we pass it, will put back on the table to those health care facilities about $70 million of real money back to them. We've heard from rural hospitals, hospital associations, all telling us, Western North Dakota, all telling us the same thing. You have to help us with our bad debt. Please help us. Please send us some money. Please stop this bleeding from this uncompensated care. There's a bill coming out of appropriations with $10 million just for bad debt. Just for bad debt. It's going to be so localized that it's not going to cover the state. Wouldn't even come close to the $225 million in bad debt. So, you know, we can turn our backs on the healthcare system. We can turn our backs on the most vulnerable population that we're here to be the safety net for. But why? What are we afraid of? I don't like the ACA. Never did, never will. That is not the point of our debate. Not even close. The point of our debate is, what are we going to do for our most vulnerable citizens? My chairman did make an error, and he doesn't do it very often. He didn't want to support the division. Of course, he doesn't support dividing this bill out, but he certainly supports voting yes on Division A, as I hope all of us do. This bill is a pro-business bill, it's a pro-healthcare bill, and it's a pro-vulnerable citizen bill. So I would certainly hope that we can support this and pass it and move on. Thank you, Mr. Speaker.
Representative Becker, second time.
Thank you, Mr. Chairman, members of the Assembly. One quick reminder, the aspect of our citizens needing a safety net. Keep in mind that for the past many years, these citizens were talking about we need to provide a safety net. That safety net hasn't been there. We didn't take that upon ourselves to provide the safety net in the past. What I'm asking the members to do is to consider what type of safety net we want for the small donut hole that remains. I'm not aware that it is necessarily a logical progression that we have to pass a bill so we can do a study to see if the bill was smart. There are many states that are not expanding Medicaid. There are many states that are. We can look at very creative ideas like Missouri. We can look at New Jersey, which I believe the governor in his wisdom is now having New Jersey be the newest pig at the federal trough. But we can look at different ideas. I may be absolutely wrong. It could be that expanding Medicaid is a great idea. It could be that expanding coverage vis-a-vis Medicaid, but really through a private carrier, is the best and smartest decision. I don't know because there haven't been any studies. Last thing, Mr. Speaker, I'd like to ask for a roll call vote.
A recorded roll call vote has been requested. It'll take 1/6 of the members to stand. Recorded roll call vote will be granted. Continuing discussion, Representative Pollard.
Thank you, Mr. Speaker. I hate to say this, but I wasn't going to stand up on this, but I have to, because of a statement that was said that the state doesn't take care of its most vulnerable. We do. I carried the bill to the floor this morning, Department of Human Services. We take care of the most vulnerable. What we're talking about is probably the working poor who don't have insurance coverage. So you're talking about the level up. We take care of the most vulnerable people in the state of North Dakota, and to the tune of $2.8 billion a biennium that I brought forward this morning. I'm going to speak about the public a little bit. I can't refute anything that Representative Weiss, Representative Porter brought forward. Can't refute it at all. Cannot do it. Wished I could. But I'll speak about people back home. When you go to the hospital or you go to the doctor, they're paying a price for that service. And if you're like somebody like a business store and they're sitting there and you're paying so much for goods, just like going to the hospital, will they reduce their prices when you go in for that doctor and physician's appointment? I doubt it. Even at the passage of this. Will the insurance companies reduce the cost of the insurance? Because there is a cost of insurance, I think roughly approximately, I heard $100 a month to cover the uninsured. Will that dollar value go down? Probably not. So if you're the independent voter at home or citizen at home looking at this and going, okay, so I'm paying more for my doctor visits, hospital visits, I'm paying more for my insurance, and now it will be to a 90-10 eventually, and I know the amendments are on the bill. When does my portion begin to stop? I'm kind of wondering. And that's what I'm going to do today is, you're probably right, it's the right thing to do, but I'm going to vote for the people back home, and I'm going to say no. And that's where I'm at, Mr. Speaker, is I will not vote for the Medicaid expansion.
Representative Weiss.
Thank you, Mr. Speaker, members of the Assembly. I guess clarify a couple points, and Representative Nelson already did cover one of them, is that this expansion will not be through the Medicaid system. It is through private, so it isn't subject to the Medicaid rates. Also wanted to point out, as we just had this morning, and Representative Pollard reminded of us, we passed the Medicaid budget. This body decided, and I think I'm correct, a 4-and-4 increase for Medicaid reimbursement. We make that decision in this assembly on what a proper reimbursement rate for Medicaid is for our providers. That's our decision. It's not the White House. We are in charge of that decision. Whether we do this expansion or not, we're still the body that decides. We've made that decision. We've increased it many times in the past. I'm sure there's plenty who think it isn't high enough, but that's a decision we make. And I'll agree with Representative Pollard from a standpoint of we do a lot for our vulnerable citizens. No question. Nobody's implying that we don't. This is just another piece in the jigsaw puzzle of the total healthcare system. And when a comment was made about the people back home, that's the reason, as much as I don't like ACA, that's exactly the reason why I'm standing up here and saying we should support this. It is for the people back home. Granted, their insurance isn't going to go down. The question is, how much will it increase? Many of these provisions in ACA are going to increase their health insurance costs. This bill will slow that increase. Why should we ask our people back home to pay the taxes and then have to pay a tax on their policy besides to pay for the people we're going to shift to the federal exchange? Somehow I don't know how that's helping my constituents back home. Yeah, there isn't going to be a drop of $100 a month because, first of all, this bill isn't going to cure all the bad debt. Nobody's implying that. Again, it's just another piece in the puzzle. But I guarantee you, premiums are going to go up because of all these taxes. So every little bit this assembly can do to limit that increase, I think makes sense for our citizens back home. And Mr. Speaker, I would ask that you would clarify what a red and a green vote means on Division A so everybody is aware of whether we're supporting the Medicaid expansion or supporting stripping out the language and just leaving the study.
Further discussion, Representative Ruby.
Thank you, Mr. Speaker. Members of the Assembly, in the past sessions when we've had discussions about expanding Medicaid, one thing that's always struck me is that we always talk about the percentage of that we go over the poverty level. Well, why do we set a poverty level if we're going to keep going over it? Aren't we there here? We've kind of agreed that we're going to help people in the most need. We're going to help people who are in poverty. We hear about the safety net. Well, unfortunately, for too many people that are helped by the safety net, they turn it into a hammock. And I think we need to make sure that we help people who need it, but we don't need to keep expanding it over and over. And I would hope that, we talk about the dollars from the federal government. Well, guess what? We pay those too. So anything we keep saying we're going to get back, we're going to get asked to keep paying in. I would hope that, and if I understand it right, we would vote no on this subdivision, if I got it correct. Thank you, Mr. Speaker.
Thank you. Is there any further discussion? Seeing none, the Speaker believes when the key is open, if you vote green, you're voting to keep Division A as part of House Bill 1170. If you vote red, you're voting to remove House Bill 11 or the section from 1170. Is that correct? That is correct. Okay. The key will be opened for a recorded roll call vote. Has every member voted? Does any member wish to change their vote? The key will be closed. The clerk will take the record. Record shows 58 yea, 35 nay, 1 absent, not voting. So Division A will remain part of House Bill 1170. Do you wish to have the debate on Division B? suppose we have to have it. Representative Weiss.
Well, thank you, Mr. Speaker, members of the Assembly. I mean, we've had the discussion. I don't see any point in continuing it. I have nothing additional to say. I would ask that you vote green on House Bill 1362. I'm sorry, Mr. Speaker. I would ask that we do vote for Division B as well. So it's part of House Bill 1362.
So, members of the House, Representative Thorson.
Mr. Speaker, just a clarification. I'm looking in laws at what's showing as the recorded roll call vote. It does not indicate that it's a division. It just says that the bill is passed in the House. Are we certain that the last vote we just take was only on the division?
I believe on the board it shows that we are voting on Division A, Section 1, 2, 4, and 5, correct? Yeah, so we will vote on the bill in its entirety after we do the next vote. Okay. So now, members, we have Division B in front of us, which is just Section 3. If you vote green, you're voting to keep it in the bill. If you vote red, you're voting to remove it from the bill. A verification vote will be held. The key will be opened for a verification vote.
Mr. Speaker?
Representative Porter.
Thank you, Mr. Speaker. On divisions, they're automatic a recorded roll call vote.
Oh,
that's
okay.
automatic.
Thank you. Has every member voted? Does any member wish to change their vote? Key will be closed and clerk will take the record. Final votes now is 93 yea, 0 nay, 1 absent and not voting. Division B is passed. The House will now have House Bill 1362 before us. Representative Carlson.
Thank you, Mr. Speaker. Members of the Assembly are probably wondering after that lengthy debate why I introduced the bill. And I did it for exactly the reason that we just did. Because this isn't a little deal, this is a big deal. And it needs to have the debate of this chamber and the people we represent have us address this issue. Because this is a door from which you walk that you're never returning. Because as long as I've been here, and Representative Kretschmar has been here a lot longer, we were discussing how many times we've stopped something that we've started. And the answer was never. So when you go through this door, you're starting a program, you're changing the rules, and you're going to fund something that you're not going to go back from. Now, I wish there was a lot more we could do about this. I wish the whole thing would have not been before us, but in the last two sessions we've spent a lot of time talking about the Affordable Care Act. And quite honestly, right now I can tell you I can't find anything very affordable about it. And that's a fact. When you look at 18 new taxes in a bill on a variety of things, you wonder, wow. The money they talk about taking from, and I always have to remember the right ones, taking from Medicare in the campaign that we're going to have to reduce that. Well, that money's going to slide over to Medicaid in the end, and those cuts will be coming. So this is a big deal that we're doing here. I think that what they did to the bill makes it much better than the way it was in the beginning. I think it adds a few little safeguards in for us, and it says if the match it changes, we can take a little change of direction. I question whether we'd have the courage to do it, but I think that at least the option is in there. But instead of studying and finding a program that addressed strictly North Dakotans, we're in the middle of a federal program. If, in fact, there's 22,000, 25,000, 30,000, whatever the number is, of North Dakotans that are uninsured, why didn't we address that issue ourselves and try to find out the best possible way to cover those people? But you know why we didn't? Because it's the allure of what some people consider to be free money. There's no such thing as free money. It's our tax dollars recycled back to us. It's not free. Somebody's paying for it, and to say, well, if we don't take it, somebody else will use it, that's true. But that's true of highway funds, that's true of every dollar we take from the federal government. We didn't set up a state exchange. We said we'll let the feds do it. We had all kinds of resolutions that said, the PPACA, we're not going to do it last session. We're not going to participate. Well, the deadline, and they gave us a little time. The committee did a good job, I think, of trying to make this as absolutely as good as they could if we're going to do it. I still struggle with the whole concept because it's an entitlement. Instead of addressing cost containment, there's not a word about cost containment for medical services in this bill. Why do you think our premiums go up 12 and 15% a year? No, there's no discussion of cost containment here. Or bundling of services, so if you have an appendix out, you might have some idea what it's going to cost. I don't think anybody knows what it's going to cost. So I think, Mr. Speaker, that we have to go down this road, unfortunately. I really struggle with this. I didn't introduce it because I wanted it to pass. Isn't that odd? I went down to the only guy who spoke against it, and I was the sponsor of the bill. That was kind of a hard deal to do. In fact, they looked at me, they said, "You don't like it?" I said, "No, I don't like it. I like it a little better today. I think that our executive branch likes it. I think our Human Services Department likes it. I think there's $9 million in the Human Services budget that deals with some other Affordable Care Act things that we have to do. And I think in the end, I'll be able to stand up here and say, I told you so, because it's going to cost way, way more money than anybody ever anticipated. But if it's going to pass, we had to make it as best bill we possibly could. The road isn't over. It's going to go to the Senate. I have no idea what they'll do. But for right now, Mr. Speaker, I just thought I had to bring up the reasons why we had to have this discussion. And I applaud all those people who dug into the information. But I don't think we still got to the root of the problem. It's like all bills in this assembly, they're driven by, and a wise man once taught me, when in doubt, follow the money. And sure, there's a lot of uncollected debt. But I could make an argument to you that I'm paying a lot of that uncollected debt in the premium that I pay every month, because they adjust that into the premiums to make sure that it does cover some of that. And there's no question about that. So let's move forward, Mr. Speaker. By the way, we have no intention of finishing today, in case you're wondering.
Is there any further discussion? Seeing none, the House has before it for final consideration House Bill 1362. The clerk will open the key and you may record your vote. Has every member voted? Does any member wish to change their vote? Key will be closed and clerk will take the record. The final vote shows 57 yea, 36 nay, 1 absent, not voting. House Bill 1362 is declared passed. The House is going to take a 15-minute recess.